All right, hi everyone. We're going to start the session today. I'm Virginia McNamer. I'm with Citizen, and today I'm going to introduce our speaker, Dr. Sonal Bhatia. She is a pediatric neurologist at the Medical University of South Carolina in Charleston. She is specialized in infantile spasm and pediatric genetic epilepsy. And she will be your speaker today, talking about pediatric epilepsy 101. So welcome.
Thank you, Virginia. Thank you for the opportunity to speak this morning. This is a seemingly basic but a very, very important topic for anyone who has epilepsy or seizures. Like Virginia just mentioned, my name is Sonal Bhatia, and I'm a child neurologist and an epilepsy specialist at the Medical University of South Carolina in Charleston. So once again, greetings from the East Coast, and I do not have any financial disclosures for this talk. In the next few slides, I will be providing an overview of epilepsy in children. So watching a seizure is perhaps the most dramatic and overwhelming experience for any of us, and especially if it is a family member whose child or loved one is experiencing seizures. So yes, seizures are scary to watch. However, learning more about them and being knowledgeable about the condition is perhaps an antidote to the fear, and that's why we are here for this awareness program for the next 2 days. I want to say at the outset that I have the highest regard for all the patients and the family members who do this day in and out with a lot of bravery, courage, and determination. And I am also very humbled as a physician about many, many things that we still do not know for sure. Overall, I like to think of this as a two-way traffic. I, as a physician, as a pediatric neurologist and epilepsy physician, I'm here to educate you guys about the topic and about epilepsy. But every single day, I learn so much from my patients and the families. They will bring up to me things that perhaps I was not well versed with, like research and updated medicines and such. So I think it's a two-way street. I think the exchange of information and the exchange of knowledge is just not coming from the physician to the patient, but obviously it's both ways. So the question that I get asked typically is my child going to be okay when the child has a seizure or epilepsy? And the answer typically is yes. So let's all take a deep breath and let's all find out what we need to do and what we need to know, and we will all make through this, and I promise to keep it brief. So what's a seizure? So in 4 easy words, seizure is a temporary brain short circuit. So 4 easy words to explain what a seizure is. And I always tell family members who bring their child to me because the child has had a seizure is that every child's brain is capable of generating seizures. So your child is not alone, and your child is not unique, and this is just not happening to your child, because every child's brain is capable of generating a seizure. The seizure can be provoked from many underlying causes, such as high-grade fever, lack of oxygen, lack of blood sugar, an imbalance in your electrolytes, if your kidney is not working properly, if the liver is not working properly, if you're on drugs or withdrawing from drugs, if you've had a head injury. And seizure is a symptom of an underlying issue when it is a provoked seizure. And sometimes seizures can be unprovoked, which means that they happen without any rhyme or reason, and the way I like to think about it is it just happened out of the blue. Seizure is a very common problem in children who are less than 5 years of age, and about 5 out of 100 children will experience some or the other convulsion in their lifetime, and that does not necessarily mean that they have epilepsy. So that brings us to the next question then. What is epilepsy? So epilepsy is defined as the tendency of the brain to have recurrent unprovoked seizures. And the old standard medical definition of epilepsy used to be that the seizures have to be recurrent, which means they have to be more than 2 seizures and they have to be unprovoked and 24 hours apart. Which means that if I had a seizure just now and then I recovered from the seizure and 4 hours later I had another seizure, that's it. That is not epilepsy. But if I had a seizure this morning and then a seizure, say, tomorrow evening, that is more than 24 hours apart. And if the seizures are unprovoked, which means I had absolutely no drugs, no fever, no trauma, no toxins, no metabolic disturbances, then that would be considered epilepsy. The new definition now for the last decade also does talk about having one unprovoked seizure, but additional tests such as EEG, which is the brainwave test, which most of you I think would be familiar with. If that is abnormal, or if the child has an abnormal neurological examination or abnormal MRI, then that puts the child at additional risk for seizures. So if someone had 2 unprovoked seizures, the risk is the same as if you had 1 unprovoked seizure, but you also had an abnormal EEG. And the third definition is that if we had a child with 1 unprovoked seizure, but if we were able to diagnose a child with a particular epilepsy syndrome right at the outset, then even that 1 seizure makes you have the diagnosis of epilepsy. So epilepsy is the same as seizure disorder. So if someone says I have a seizure disorder, that just means that you have epilepsy. So these words essentially mean the same. Epilepsy is not a one-size-fits-all disease. There are many causes with varying outcomes and prognosis, as we will see subsequently. And it is not a problem confined to the United States alone. It is a global problem. In the United States alone, there are 470,000 children with epilepsy. This map right here gives us a distribution of the burden of pediatric epilepsy cases by state, and the state of California, the state that we are in currently, has perhaps the highest, it has the highest number of epilepsy cases in children. About 60,000 children with epilepsy alone are in the state of California. And my state on the East Coast, South Carolina, where I practice, we believe that close to over 7,000 children have epilepsy in the state of South Carolina. And you can see the different shades in this map represent the different numbers of children that have epilepsy by the state. So like I mentioned earlier, that epilepsy is not a one-size-fits-all disease. And just like every child is unique, and if as a parent you have 4 children, you know that each child is different from the other. They are all your children, but they are all different, they are all unique. And similarly, epilepsy too is unique to each child. So I have a very different approach for each child depending upon the child's condition and the family dynamics as well. So again, like I said earlier, it is not a one-size-fits-all disease. There are many, many causes. Each child behaves differently. The outcome of epilepsy or the prognosis of epilepsy is different in each child. Historically, we felt that about 3/4 of the cases, we did not really know what was going on, and we didn't know what caused epilepsy in those cases. But now with more and more genetic testing available, we believe that at least about 1/3 to maybe half of those cases are genetic in origin. Pediatric epilepsy is also very unique because epilepsy and seizures in children can change as the child's brain grows and matures and develops, which is a little bit different from adults who have epilepsy, whose brains are not growing and maturing. And the good news for me as a pediatric epileptologist and for families whose children have epilepsy is that a vast majority of the children, about 70% of the children, if their seizures or epilepsy start before the age of 12, they will be able to outgrow that condition. Seizures are not only the problem in children, but we also know that children go to school, they do a lot of learning, their brains are active all the time. So what is also unique for me as a pediatric epileptologist is that I have to be cognizant of the effect of seizures on a child's learning and school performance, and I have to be also very cognizant of the treatment that I provide to the child and the effect of that treatment on a child's learning and school performance. So we use various medications, and they have varying degrees of effects on an immature developing brain. And like I mentioned earlier, that I tailor my approach to a patient with epilepsy depending upon the child's condition and the family's socioeconomic condition, as well as their dynamics. So the first and the most important step here is to make the diagnosis of epilepsy, and this is done really in 4 easy steps. So the first question, when I have a child, a patient comes to me, suspected seizures or seizure-like activity, the first question that I ask myself, is this a seizure? And once that question has been answered as yes, this was a seizure, then the second step that I go is to figure out if this was a seizure which was a generalized type of a seizure or a focal type of a seizure, which we will discuss more in detail subsequently. And once we figured that out, we try to figure out if the child has an epilepsy syndrome. And then finally, the most important thing, what was the reason why this child has epilepsy? Do we really have a cause? So let's go to the first question, is this a seizure? So kids do a lot of funny things, right? I mean, the kids can have a tantrum, they can have a tic, they can faint, they can daydream, and that lady there almost looks like one of the Disney characters. So who knows what she's doing over there, maybe casting a magical spell. But one thing important to know is that not everything that shakes is a seizure. So the first and foremost thing is to first understand that, is your spell in question a seizure? Because there are umpteen number of cases where a patient did not, or a child did not have seizures or epilepsy, but they were treated as such, and even vice versa, that they had seizures or epilepsy, but they were treated as not having epilepsy. So both things are detrimental to a patient or a child. So, and a very, very important take-home message here is that epilepsy is a clinical diagnosis. No test can confirm epilepsy. There are tests that can support the diagnosis, but epilepsy is a clinical diagnosis. I feel that this is definitely one condition where the question as to is this a seizure will not be able to be answered by Dr. Google, right? And that's one question which needs a real doctor, and so I'm glad that I can get to keep my job, because that question can be only answered if you meet a epileptologist or an epilepsy expert. And I often tell the families that my work is like a detective, like Sherlock Holmes or maybe the FBI, that I come in after the crime has been done, and I am like a detective trying to put the pieces of the puzzle together and then trying to give you guys an answer. What was this event in question really a seizure? So we ask a lot of questions, and some of you may have experienced this with your physicians and your doctors. So I like to know what happened to the child before the event, during the event, and after the event. So I like to ask the family, was the child stressed? Was there lack of sleep? Were there some medications that were given to the child? Was the child sick? Which is a very, very important question in pediatric neurology and pediatric epilepsy. Was the child sitting or standing or sleeping? Because if you have certain spells that happen only when the child is standing, that may be a syncope or a fainting and may not necessarily be a seizure. Now, during the seizure, we like to know what time of the day it was. Was it when the child was awake, when the child was sleeping? If we have slightly older children, we also like to ask if they felt a warning or what we call a seizure aura before the seizure was happening. The child did feel a funny sensation in their stomach or had abnormal vision or abnormal sensation. And then how did the seizure begin? Was the child shaking? Was the child staring? If the child was shaking, how was the child shaking? What part of the body was shaking? Was the child responsive to you? What was the color? Was the child blue or pale, or was the color normal? Did the child lose their bladder or bowel? Did they have tongue biting? And of course, most importantly, how long was the event? And then afterwards, things like, was the child confused or tired and was unable to speak, maybe complain of a headache or muscle soreness, had no memory of the event. All of these give us an understanding of what the event was in question. But you guys, when parents come to us and the child has had a first time seizure, I mean, I'm very sure that there is panic, there is fear, and you perhaps do not know that you come to a doctor's office and you'll be asked all of these questions. So now that you guys are here and know some of these things, I think it's good to pass on this information to other friends or other family members whose children may have seizures, to give them a heads up as to what the doctor will be asking you when you go to see a pediatric neurologist or an epileptologist. So just like our tongue tastes different flavors and there are different spices and such that we use in the kitchen for cooking, similarly seizures come in different flavors, and there are over 40 different types of seizures. Can range from someone who's staring, someone who's fumbling, someone who is jerking, to the full-blown generalized convulsive seizure that you guys know as grand mal seizures. So once again, seizures are of different types, and once again we rely on a good history taking and a good story to give us an understanding of what type of seizure the child may have had. Then once we have confirmed that the event in question is a seizure, the next step to figure out is, was this a generalized seizure? And the way I think about it is, generalized seizure means the whole brain is on fire, or the way I tell the family members is, think of the entire house being on fire all at once, versus a partial or a focal seizure which arises from one area of the brain. In other words, the way I think of it is, it's not the entire house on fire all at once, it's perhaps just one room of the house that's on fire, and perhaps the fire may just stay in that room, and that's a focal seizure, or sometimes can spread from that one room if it is not controlled in a good time and can engulf the entire house, which we in medical terms say it as focal to a secondary generalized seizure. Of course, our history is always the key, very, very crucial in giving us a clue whether it's a generalized seizure or a focal seizure, but the brainwave test is also a very good guide in figuring out to some extent if the seizure was of generalized onset or a focal onset. And this classification is very important at the outset because it helps me as a provider to choose certain medications for children with seizures and also to avoid certain medications. Now, once again, like I mentioned, the diagnosis of epilepsy is clinical and the tests are all supportive. So right at the top is our history and physical examination, a good neurological examination, and that really is perhaps the only way we make a diagnosis, and the rest of the tests are supportive. So EEG or the brainwave test, like I mentioned earlier, can give us an understanding of generalized versus focal type of epilepsy. We do blood tests also in children with epilepsy. Most of these are for genetic etiologies, to test for certain genetic conditions. But if you had a first time seizure and you were in the emergency room, sometimes your blood may be tested for infections, drugs, metabolic disturbances, checking your sodium, checking your sugar, calcium, etc. Then we have imaging, which is a CT scan or an MRI to look at the picture of a child's brain to figure out the cause of epilepsy. And then we have some specialized testings as well, a MEG scan, which is a specialized form of EEG, which is done in children that have very difficult to control seizures. And finally, we also sometimes like to order an ECG or an EKG, which is the rhythm strip of the heart, because cardiac arrhythmias and certain cardiac conditions can cause a person to faint and even shake and convulse. So we want to make sure that we are diagnosing seizures as they are and not mistaking a cardiac disorder for a seizure. Now, if you guys are wondering why am I showing you these pictures of these phones, and I think sure some of you in this room have not even seen or don't even know what this picture on the left looks like, the old phone. And everybody I think knows the picture on the right, which is the new phone which all of us have and all of us use. So think of the picture on the left, the old phone, as a CT scan. Okay, the CT scan or a CAT scan is a old way of looking at your brain. And the thing on the right, the iPhone, the new phone, is an MRI, which is the new way of looking at a child's brain. These are both looking at a child's brain, just as you guys are looking at the pictures of both these phones. But they are both phones, they are both doing the same function, but they are different, like really, really different. We all really know that. So when it comes to brain scans or brain imaging, we are trying to look at a picture of the child's brain to look at the structural integrity of the brain. And we mostly use the new phone, which is the MRI. Sometimes in emergency cases or certain rare conditions, we would still go to the old phone, which is the CAT scan. So the good news is that not all children with epilepsy require a brain scan. Of course, all children these days need a phone, but they all do not all need a scan. So there are certain times when we really want a brain scan. If a child has an asymmetry on the exam, weakness on one side, or we find abnormal examination of the skin and certain stigmata on the skin, so conditions like tuberous sclerosis is where we would like to get a brain scan for a child. If the child really shows regression in their development, which means that they are developing according to their age and suddenly they stop developing, or they regress, which means the child knew their alphabets, they knew how to walk, they were toilet trained, and then now suddenly the child cannot do any of that, those are the children we would like to get a brain scan. If the child has persistent focal seizures, which means the seizures start only on one side of the body, we want to make sure that there is nothing on the opposite side of the brain that is causing the child to have focal seizures. Certain seizure types in very young babies, such as infantile spasms or myoclonic seizures, those are the times we would require a brain scan. If we, for whatever reason, we cannot come to a conclusion as to why this child is having seizures, those are the children also we require a brain scan. And of course, if the seizures are very challenging to control and the child has had a seizure relapse. The children that don't need a scan are those that have a primary generalized epilepsy, and like I explained to you earlier, this is the type of epilepsy where the entire brain is on fire all at once. So there are certain types of primary generalized epilepsies which particularly do not require a brain scan. Children also have epilepsies that they outgrow, so the benign focal epilepsies, and those are typically we don't like to scan unless we have certain red flags in the clinical presentation. Children with simple febrile seizures do not need a brain scan. And if your EEG is abnormal is in quotes, that alone does not require a brain scan, because we have to take into account the clinical story. Like I said earlier, epilepsy is a clinical diagnosis, so having an abnormal EEG does not really mean you have epilepsy. You shouldn't be treating an abnormal EEG, and those are the kids that just do not require a brain scan. So we have to put, like I said earlier, we are like the FBI, putting the pieces of the puzzle together to come to a conclusion. So we can think of seizures as earthquakes of the brain or quakes on the brain. And thankfully, earthquakes are overall rare. However, in areas that are prone to earthquakes, a seismograph picks up abnormal seismic waves radiating from the focus of an earthquake. Similarly, our seismograph is the EEG or the brainwave test that is picking up abnormal brain waves from a seizure focus. What our EEG does is, because earthquakes are rare, obviously if you did an EEG for 30 minutes to an hour, we are less likely to pick an actual event or a seizure, but what we sometimes pick up is abnormal waves from a seizure focus that give us a clue that the child may have epilepsy. But like I mentioned earlier, having an abnormal EEG is not enough, because if you randomly did EEGs on, say, 1,000 kids here in Disneyland, perhaps a small percentage, say 3 to 5% of those children might have abnormalities that we see in children with epilepsy, but they will never have a seizure, nor do they have epilepsy. And similarly, in about 20 to 25% of our children who actually have seizures and epilepsy, EEGs are going to be completely normal. So the EEG is not helpful in diagnosing it. It just gives us a clue. It's just an aid, but it is not by itself sufficient, because you may, like I said, you may have epilepsy, but the EEG may be normal time and again. So once again, I want to emphasize that EEG helps in aiding our clinical diagnosis, and an abnormal EEG does not mean that your child has epilepsy. EEG is also used for classifying seizures, like I mentioned earlier, generalized versus focal seizures. Sometimes having an abnormal EEG gives us clue for an underlying structural lesion in the brain, such as a tumor or a growth. We have certain EEG patterns that we see in children who have certain neurodegenerative disorders and certain genetic conditions. There are certain EEG signatures for certain disorders, although they are not specific. We use EEG to monitor treatment response. So the child has a seizure, has epilepsy, has an abnormal EEG. We treat the child, and then we look at the EEG sometimes to understand if the child is responding to our treatment. And then before we try to wean medications in a child, we also like to do an EEG. And then, of course, if the child has treatment-resistant or refractory epilepsy, these are the children who will perhaps undergo an evaluation for epilepsy surgery. And there are a lot of talks here in the next 2 days on epilepsy surgery. And those are the patients, or those are the children that will require a thorough EEG before we are able to surgically evaluate them. Now, coming to genetics and epilepsy, it's a very important topic, and it's a topic that is close to my heart. I have a special interest in genetics epilepsies, but I think in one phrase I can just sum it up and say that the genetics of epilepsies is complicated. It's not straightforward. And very often I get this question from family members, parents: if I have epilepsy, will my child also have epilepsy? And in the vast majority, the answer perhaps is no, because in the vast majority, the epilepsy is not inherited. And honestly, with all the tests that we do, sometimes we really don't have a cause. Like I said earlier, that overall about 30% of the children will have a genetic basis that we are able to identify with the technology that is available in today's day and age. This technology is expanding. Currently, we have about 24 genetic testing, but as I'm speaking to you, more and more genes are being added to the pool, more and more tests are being added to the pool. So perhaps not, if not in my lifetime, and maybe not in your lifetime, maybe in the next generation for the future, we may have more answers than we do currently. So I spoke all along about what I do to diagnose epilepsy. I take a history, I order an EEG, I order a brain scan, maybe I order a genetic testing. But have you guys ever thought, what can you do as parents to help me get a diagnosis? So the easy thing that you can do is, are you recording? Okay, this event or this talk is being recorded. The simple question that I want to put forward to all of you guys is, pick up your cell phone and record. It's very easy. Gone are the days where we needed this to record, right? So you have a cell phone, and if you have a child who's having a seizure, first and foremost, of course, keep the child safe. But then if you have help, and then if you have someone, just have that in your brain as a knee-jerk reaction. Oh, I have a child who's having a seizure, perhaps the first time seizure, or child who has infrequent spells. Once again, having a video is extremely useful, because a video is really worth 1,000 words. So all the questions that we ask you about, what was the child doing during the seizure? Was the child shaking? Was the child staring? What was the color? What was the responsiveness? I think all of that can be very, very easily answered if really we have a video to look at. And let's just look at what points should be considered when you guys are recording a child with seizures. So once again, like I mentioned, safety of the child is very important. If the child has a seizure, of course, first make sure you have help and the child is safe. And then if there is a chance, try to record a video and try to record the entire event as much as possible. Try to include the child's entire body. Make sure that the light in the room is good so we can see the child better. Very often I'll get videos from children who are sleeping in the bed and the room is dark and there's a video and I just cannot see anything because there is no light in the video. Make sure to include audio, and then also make sure to talk to the child during an event if you are able to, so that we can gauge if the child is responsive or not during that event. So history, EEG, MRI, genetic testing, video recording. Once all of that confirms that this is seizure and this is epilepsy, the next question really is what causes epilepsy, and really the goal of all of this exercise is to ultimately figure out why someone has epilepsy. So this slide gives us some of the common causes of epilepsies, ranging from infections to stroke to tumors to genetic etiologies, and sometimes we just may not have a cause after repeated testings in some of our patients. Well, all of these causes of epilepsies do exist. I think one important thing to know is that epilepsy is not contagious. This is still a belief in many parts of the world outside the United States, so I wanted to just emphasize that epilepsy is not a contagious disorder. And then this figure out here again divides the causes of epilepsy by a child's age group. So like I mentioned, children's brain are developing, and depending upon what stage of development the child is in, they will have different causes of seizures. So infections are really, really important in our young infants, and then adolescents, tumors and other conditions are important causes in that age group. So then third step then is to try to fit the child into an epilepsy syndrome. So we take into account the age of the child, we take into account the EEG findings, and then we take into account the type of seizure that the child is having, and then try to define if the child has an epilepsy syndrome. And this is again very important to decide what treatment we offer to the child, and then it's also very important to understand the outcome or the prognosis that the child will have, because each syndrome has different outcomes. So then once a diagnosis is made, then we want to talk about treating the child, and typically we try to treat children with seizure medications. That's our first line, and if the child does not respond to 2 appropriately chosen seizure medications at the appropriate doses, then that's a child that we think has difficult to control or refractory epilepsy, and then we resort to other methods such as the ketogenic diet, implants outside the brain such as the vagal nerve stimulator, deep brain stimulator within the brain, or responsive neurostimulation as well, and you will have some talks later today and tomorrow on those topics as well. And then finally, certain children may be candidates for epilepsy surgery to try to see if a focus from the brain can be surgically removed to cure their epilepsy. So a few important considerations when we are trying to treat children with seizure medications. So first and foremost, you give your child a seizure medication and the child does what Elaine is doing over here, right? The child just spits out the medication, so really no use, right? So I think it's super important to work according to the child's development so that the child is able to take the medications properly. You may have to crush tablets, you may have to powder them, you may have to use a sprinkle form. Very often I hear from parents that the child cannot swallow the pills, and sometimes there are certain medications that are only available in a pill form, and then we are stuck with what do we do? There's no compounding pharmacy, there is no liquid preparation, so what do we do? So I tell parents that maybe go home and practice swallowing pills with your child. So the child takes perhaps a small, say maybe a Tic Tac, and then you guys take a multivitamin, and then just have a role play at home that you are swallowing a pill, the child is following you, so the child knows that it's going to be safe, I'm going to be okay if I swallow a pill. So that can be done. And then obviously super important to stay regimented, even if you are out on the summer camps or weekends, or if there are 2 separate houses that the child may be living in. Very often I get to hear that I'm not sure what happened at mom's place or what happened at dad's place, if they gave the medication or not. So very important that there is consistency in administering the medications. Of course, we have pill boxes that can be used to organize pills for older children and teenagers. There are a lot of pill boxes in several of the booths outside over here. Certain apps and certain companies, Medicine on Time helps us stay organized. There are apps. And then teenagers, my friends, teenagers have to be watched with 4 eyes. 2 eyes are not enough for them, right? Now, coming to certain medications that have specific side effects or specific considerations in children, so dilantin or phenytoin, an old medication, not very much used in children these days, but sometimes still may be used. Very, very poor absorption in children, so it's not very clear how much is being taken, how much is being absorbed in the bloodstream as well. Medications like phenobarbital, which is still used fairly commonly in neonates with epilepsy, can sometimes cause issues with hyperactivity, may also affect the child's IQ. The same goes for medications like Keppra, which some of you may be familiar with, as well as benzodiazepines. Medicines like Depakote, especially in young children less than 2, can cause liver injuries, and then we always worry about Depakote and its adverse effects in young girls, in teenage girls who are of reproductive age or childbearing age. Medicines like Topamax can slow down a child's processing speed, can cause the child to have word finding difficulty. So we used to call this medication Dopamax, which means that it just feels like somebody's on a dope, somebody's on a high. Lamotrigine, about 10% chances of causing a rash. So if I use lamotrigine in 100 children, 10 of them can have a rash. And then certain special medications which we only use in children, Vigabatrin, which is specifically used by pediatric neurologists for infantile spasms in tuberous sclerosis, and medicines like stirupentol that we use for Dravet syndrome. So now that we looked at some medical aspects of seizures and epilepsy, let's just switch gears to talk about some practical aspects of these conditions. So the most important advice that the parents need who have children who have first-time seizures or newly diagnosed epilepsy is what to do during a seizure. It's easier said than done. I am standing in the clinic and talking to them. They are actually in the house or in the school or in the playground facing their children with seizure. But the first and the most important message is stay calm. Everybody functions well when things are calm, but if everybody starts getting jittery, then things start kind of falling apart. So stay calm, and the first and the most important thing is to try and protect the child from physical injury. So to make sure that the child is in a safe spot. If the child is in a position where the child may fall or hurt themselves, try to keep them in a safe spot. Clear out the area of sharp objects or hot irons or hot water that may cause burns and injuries to the child. Put the child in a lateral position, which means turn them on their side, because that way it's less likely that they would aspirate from their saliva and their vomitus. And then do not put anything in the child's mouth. During a seizure, when the child is stiff in the tonic phase of the seizure, the jaw is extremely tight. So if you try to put something in the child's mouth, you may cause the child to have dislodged tooth, and or worse, you may just fracture your finger. I have had a couple of patients very early on when they did not really know what to do during a seizure. One mom tried to put her finger in the child's mouth she felt like the child would just swallow their tongue or choke, and then she was left with an amputated finger because the force of the seizure was really, really so strong. Of course, most children will turn out fine during a seizure. We all feel that the child is not breathing, but that seldom happens. Do not attempt a CPR during a seizure because it's almost not possible for you to just be thumping on the child's chest or breathing in their mouth when they're really actually having a seizure. And if the child has rescue medications prescribed by a physician, then follow those instructions. Typically, we try to recommend rescue medications at the 5-minute mark of a convulsive seizure, but this can vary from patient to patient. Sometimes there are patients that might need the medication at the 3-minute mark. I have patients that need the medication as soon as the seizure starts because their seizures just are always prolonged. So follow instructions from your physicians. Call for medical assistance or call 911 if you guys are not sure the child is doing well after the medication administration, or if you still feel that the child is in a seizure despite the medication administration. Or first time parents, I always tell them that you guys are not used to this, so I would be okay if you wanted to call 911 a few times till you get comfortable that this is all going to turn out to be okay. But then I have patients, what I'd like to call seasoned families. Unfortunately, kids have several seizures. They've been doing this for years, and they don't call 911. They just know how to manage things at home. The next most important is seizure safety, and whether it's at home or school or at the playground. And the general advice that I like to give is just use common sense that you would use in taking care of a child, even if the child did not have seizures. So there are so many things that parents would say, don't go there, it might hurt you, or take it easy, or you may fall down. So please use that even if the child has seizures, because the child with seizures is no different from a child who does not have seizures. I also like to hand out this half pizza that I like to call during my seizure safety advice, and this half a pizza has 3 slices, or 3S. The first stands for swimming. So talk about seizure safety when they are swimming or around water or taking a bath or shower. The second slice talks about step ladders, so climbing heights. Typically not a problem in children, but adults, of course, they might be working in climbing ladders, etc. So for the adult population, this perhaps is more applicable, not so much for children. And the third thing is steering or driving safety. So talking to all my teenage patients about when and how they can drive. And then this slide, it's a slide from Epilepsy Foundation, which is a very good resource for all the parents and caregivers whose children have first-time seizures. So this talks about safety in the home, in the bathroom, in the bedroom, and around the house. So when it comes to cooking, again, not very applicable for young children, but our teenage patients prefer that they cook with a parent or when someone is in the house. So in case there was a seizure, there is someone to take care of them and there are no accidental injuries. Prefer that they work with a microwave to cook meals, but not a gas. Also prefer that non-breakable dishes are used. So if in the event of a seizure, there is not injury from a broken glass or a broken ceramic dish. And then obviously we want to use caution when there are hot liquids and hot food items around. In the bathroom, I like to tell the patients with seizures and epilepsy is prefer showers to bath. And if you are taking a shower, also just make sure that you close the door but don't lock the door. So if you had a seizure inside the bathroom, someone can reach you. Make sure that the water temperature of the shower is adjusted in such a way that it is hot, but it's not too hot that if you were to have a seizure in the shower, it would not cause burn injuries. And then have a non-skid rubber mat installed outside the shower so the child, if they were to fall, again, would not get hurt. And then padding the furniture, etc. I did see as I was walking across the exhibits about this nice padding that one of the moms created. It's just a little rubber pad that can be used on countertops or in school for the benches and the desks. So the child were to fall during a seizure, they don't smack their head as they are hitting the countertop. So I advise that you all can go visit that, because that was a very cool thing to address seizure safety for children. Coming to sports, all of us want our children to be active, play, have fun, and children with epilepsy are no different. And you guys as parents and we as physicians also want children to be active, because physical activity is so important not only for your physical health but also for your mental health. So all these sports that are listed in the green are okay for children with epilepsy. It's absolutely fine. Of course, we do take this on a case-by-case basis, and sometimes if children have difficult to control seizures, we like for them to wait it out a little bit until their seizures are a little bit more stable. However, this this slide here and things on the red are a complete no-no for children with epilepsy, especially paragliding and scuba diving. But once again, try your best to use common sense when it comes to seizure safety. The next question I get asked a lot is, what about video games? Video games are lifelines for children. Video games and phones, right, are essentially the lifelines of children when they're at home. And the question that I like to get asked all the time is, did the video game cause epilepsy in my children? So the answer is no, video games do not cause epilepsy. And then I get asked, basically, can my child play video games? So the answer to that question is that video games, when they have flashing lights or strobe lights, are only basically contraindicated in children that have photosensitive epilepsies, which is again a very small percentage, sort of 100 children, perhaps 3 children. So the vast majority do not have photosensitive epilepsy. And one of the ways of figuring that out is when you guys take your children for EEG, and there is an EEG done. They have strobe lights, and specifically if the EEG triggers abnormalities during a strobe light stimulation, that constitutes photosensitive epilepsy. So if your child does not have that, then by and large, of course, the child is safe during a video game. But if you guys are still unsure, try to watch the child's behavior as the child is playing a video game. And if you feel that the behavior is different or there is something else that you observe, once again, try and take a video if possible and then discuss with your doctor. For the small percentage who have photosensitive epilepsy, we recommend that the child play in a well lighted room, so that we are reducing the contrast from the video game screen and the ambient light. Try to keep the screen as far as possible. Again, everything in life has to be done in moderation, so just do not sit there for like 20 hours out of 24 hours playing video games. That's not good for anyone, whether you have epilepsy or not. Everything in moderation, everything in balance. Take regular breaks, look away from the screen once in a while. So if you're focused, just try to take breaks, take physical breaks, but also try to look away from the screen once in a while. And then sometimes I like the parents to tell the kids as well, is that try to cover one eye alternating, and that kind of breaks the stimulation from the strobing lights. And of course, if you develop any strange feelings or jerks or any unusual movements, please stop. Just talking very quickly on this important topic of teenagers with epilepsy, and since I see children, I also see teenagers. Again, if you look at this slide here, there are 4 teenagers pictured out here, and I don't think anybody in the room can say that which of the 2 have seizures and which of the 2 do not. The point is that teenagers with epilepsy are just like any other teenager. They should not be discriminated. They should not feel that they are the only one. They should just not feel that they are alone, because you can still have a normal life despite having epilepsy. So the first question that I get asked with a teenager is, can we drive, right? So every teenager is waiting for their driving birthday as to the day when they will be able to start driving. And the question that I get asked is, when can I start driving? Am I supposed to inform the DMV? And the answer to that is that it is state dependent. And Epilepsy Foundation is once again a good resource. If you just Google Epilepsy Foundation driving, put your state, it will give you exactly the laws for a particular state. Just for comparison, I'm not sure if it's very clear over here, but just for comparison, I just put California, the state that we currently are in, and my state, South Carolina, to see how the driving laws differ. So for my state, it's about 6 months of no seizures before a teenager can start driving. Sounds like in California, it's about 3 to 6 months, depending upon an individual case. Life is all about do's and don'ts for all of us, and most importantly for our teenage patients. Do this, don't do this, and that is also applicable for teenagers with epilepsy. So make sure that you do not compromise on your sleep. Make sure that you get adequate sleep. Everything else in life can wait, but make sure you plan your day in such a way, organize your day in such a way that you sleep well. Just before I was coming here, I had my clinic and I saw a Hispanic patient who was seizure-free for a year, and then had a seizure early this year because she stayed up the entire night because she was worried about school the next day. She came back from school and had a seizure. So do not do that. Make sure that you do not miss your medications. I've had teenagers seizure-free for years come in with breakthrough seizures and injuries and swear to God that they took their medication. They swear on their mom, their dad, they swear on me that they've taken their medications, and then I check their blood levels. Not detectable. That cannot happen unless you have skipped your medication. So do not get lax. Take your medications on time, and then absolutely no drugs, no alcohol, especially for teenagers with epilepsy. The things that you can do is you can have friends. I'll take a moment here to remember Matthew Perry, who just passed away, and you can just see what happened, right? Drugs and alcohol was really the reason, right? So, well, you can have friends. If you have epilepsy, absolutely have a normal social life. Please stay away from drugs. You can go to college, get educated, have professions, not a problem at all, get married, have children, all of that. So bottom line is that even though you have epilepsy as a teenager, you can still lead a normal life. Just very quickly, talking about epilepsy in women, even though I do not see that very much of a problem because I'm a pediatric neurologist, once in a while I will have a teenage girl who gets pregnant or wants to discuss that issue with me. I remember when I was a resident, at 8 o'clock in the evening, I was on call and I had a phone call from a mom who was panicking because they had an ultrasound in the morning and the girl was 3 months pregnant and she was on Depakote. And I was like, okay, you found that out in the morning and you're calling me at 8 o'clock in the evening. Why did you not call me in the morning? And so trying to figure out, because Depakote is a medication that can have potential side effects to the developing fetus. Such things do come up once in a while, but for the most part, teenage girls, if they want to have pregnancies and babies, they will still be okay despite the fact that they have epilepsy. Very important that we discuss pregnancy planning with our physician prior to really becoming pregnant, and then even though you know you're pregnant or are about to be pregnant, please do not stop seizure medications until you take advice from your doctor. Contraception is an important topic that I would like to briefly touch. Oral contraceptives do get affected by seizure medication, so sometimes we have to resort to alternative means of contraception for those teenagers with epilepsy. And then every girl or teenage girl in the reproductive age group should be prescribed folic acid supplementation if they have seizures, epilepsy, and are taking anti-seizure medications. Very quickly touching upon school issues and learning problems in children with epilepsy. So for me as a pediatric neurologist and pediatric epilepsy specialist, epilepsy is much more than seizures because I do see a bunch of learning and behavioral problems and school issues in children with epilepsy. So this table on the left does talk about the incidence of problems like ADHD, learning disability, depression and anxiety in children with epilepsy. And to some extent it's the seizures themselves that cause some of these problems. Sometimes it's the medications that we use that may be contributing to these problems. But all in all, I think we have to be cognizant of the fact that epilepsy is much more than seizures in children. So how do we approach these issues? At my institution, at the Medical University of South Carolina, we work very closely with the Child Psychiatry Department and the Developmental and Behavioral Pediatric Department to address these issues. Like I mentioned earlier, if the child has poor seizure control, the child will have difficulty with their behavior, with their learning, with their mood, they'll be anxious. So for me as a pediatric epileptologist, I like to ensure that I provide as optimum a seizure control as possible. And like I mentioned earlier, that sometimes it's the seizures that contributes to the learning problems and sometimes it's the medications itself. So I want to make sure that I'm minimizing the effects from my treatment to enhance the child's learning in school. And then I like to select some seizure medications that might have a benefit on the child's mood or learning or behavior. One such medication is lamotrigine. I've had several patients on valproic acid or Depakote. Depakote is also a great mood stabilizing agent, and I have had several kids that for years have been seizure free, but the parents don't want to take away the Depakote because it's helping the child's mood. So sometimes the seizure medications can also help with the child's mood. Of course, we need to consider an individual family situation. Different people have different baggages that they carry. Different families have different baggages. So we want to make sure that we, understand and are cognizant of all of that. Sleep is so important. I came from the East Coast to the West Coast. I am a little jet lagged, so sleep was a little off because the time changed. So I was a little cranky yesterday morning. So you can imagine if you're not sleeping well, you may not be able to focus, you won't learn, your mood will be off as well. Like to use objective measures to address these issues rather than just thinking, oh yeah, maybe the mood is off, yeah, maybe the learning is off. So there are certain objective scales that are very helpful in understanding from visit to visit if the child is doing well and his child is responding to treatment. And when I do the screening tests and if I find some issues, then I of course like to address safety. Always important to ask for suicidality, suicidal ideations, plans, etc. first and foremost, we recommend counseling, talking to a close confidant in school or in church or in the family. Very, very helpful. And then sometimes choosing medications to help things like ADHD and mood is also very, very helpful. And then, of course, we like to make sure that these children follow up very frequently. Many children that I just mentioned that I see are not having seizures, and I'm just sometimes treating their mood with Depakote. So they still come see me, not for seizures as such. The seizures are gone, but we are still, working with their mood and things like that. Last few slides. Schools, again, super important. We want to be inclusive. We want to make sure that the child is not left behind and that the school is doing their bit to include the child with epilepsy and making sure that the school is a safe environment for them, so the children and the families don't feel that they are different, or they don't feel a stigma, they don't feel left out. And from a medical aspect, Epilepsy Foundation does talk about schools being epilepsy smart, and does talk about each school having an individualized seizure action plan to ensure that the school and the school staff know what to do during a child's seizure, what rescue medications to offer, etc. And then obviously the school staff and the teachers have to be super aware and empathetic towards a child's seizure disorder. I've had several patients where basically the sibling is being bullied in the class because the sister at home is having epilepsy, so the child can't go to school. So we have to be very, very cognizant of that. And lastly, I would like to say that there is no better advocate for children with epilepsy than you as a parent. You've known your child since the first breath, and you need to speak up, ask questions, keep us on our toes so we are able to take better care of children with epilepsy. And with that, I would like to end because it looks like the next speaker is ready here in the room. Thank you very much.